general surgery resident at Georgetown and Washington Hospital Center, spending my year right now with the trauma department. But before I get started, I just really want to express my gratitude for you all for being here and for being our nurses and being the voices of our patients. Because as a resident, I know from my personal experience that I rely heavily on our nurses to let me know what's going on with their patients. You spend much more time than I do with the patients themselves, and sometimes you have more keener eyes than I do about changes that are happening from minute to the next minute. So the purpose of the next 30 minutes with you is not for me to just talk at you, but I really hope that whatever you gain from this presentation is going to be helpful for you taking care of your children, pediatric patients, and even some family members who may be getting a chest injury or a chest surgery and would require a chest tube or a pigtail. I personally learned from my experience that every rotation that I rotate through, it really applies to not only the patient that I'm taking care of, but my personal life in terms of how I care for my family. So with that started, we have 3 objectives here. The first is to familiarize with different types of injuries that could be caused to our chest, and to know the indications and appropriate handling of chest draining devices. This chamber right here that you see in front of you, this looks like just a blank box, but it is very intricate. And then the way that you handle it is going to impact the patient's outcome. The third is to identify alarming signs of decompensation. So before we move on, I just want to make sure that to disclose that I do not have any financial conflict of interest. All the images are not my personal images. They're either from the trauma department or from the internet. So, as a general background, since this is trauma core, I just want to share the statistics with you that the injuries are the leading cause of pediatric mortality. And of these 3 mechanisms of injury, what is pertinent to us is motor vehicle accident. So, thoracic trauma is the second leading cause of mortality in pediatric trauma, and it increases mortality risk by 20 factors in a patient who is multi-system injured. And it is responsible for about 4.5 to 8% of the patients who are treated at pediatric trauma centers. So when you hear chest trauma, it's easy to think about the lungs since they occupy the most dimension in our chest area. However, you have all these other organs and anatomy in the chest. You've got the esophagus, aorta, the heart, the lungs, the pleura, the sternum, and then the rib cage. And when we talk about chest trauma, we kind of categorize them into 2, blunt injuries and penetrating injuries. For blunt, it's things like motor vehicle accident, pedestrian struck, or fall. For penetrating, it's generally a stab wound or a firearm, or it could be that a kid falls from a branch and then there was a ladder and they fell, and that could become a blunt with the penetrating if a piece of metal got into their chest cavity. So because there's just so much it's contained within our chest cavity, we have a wide range of differentials from rib fracture, lung parenchymal injury, and pulmonary vessels injury, just to name a few. But it's important to note that unlike us, who have very robust bones, for pediatric children, their bones are very malleable. So it's possible that they may have a lot of significant internal injuries without external injuries such as a rib fracture, which you may be able to palpate on exam. So you may have heard of pneumothorax and hemothorax. Pneumothorax is when air is occupied in the pleural space outside the lungs. And because of that, the lungs are not able to expand, and then the kid would become tachypnic, and then the saturation would go down. Hemothorax is in that space where if it's contained by blood. And of course, in pediatric trauma and in adult trauma, one could have a combination of these 2. Now, as I mentioned before, kids, they have very malleable ribs. So instead of getting a rib fracture, they could instead get a pulmonary contusion, which is pretty much the bruising of the lung parenchyma. And when the bruising happens, just like on our skin, there's hemorrhage. There's microvessel hemorrhage and edema. And because of that, there's poor gas exchange. And then when you examine the patient, they may have low saturation despite high oxygen supplementation, despite overt external injuries. And of course, the critical organ of the heart. One could have a blunt cardiac injury without any external signs. And then the kid could have a arrhythmia or chest pain, and these could be very subtle to identify and diagnose. So we'll come up with a scenario. So at this hospital, at the Level 1 Trauma Center, we have two different types of trauma activation. First is this trauma stat, and that's when the emergency department and the trauma surgery residents are present. And then the highest level of trauma activation is the trauma stat attending. So say you're in the ED and you get a page and you hear from the overhead that there's a 14-year-old with a gunshot wound to the right chest after an altercation. She was unresponsive and hypotensive on scene, and therefore she was intubated by EMS and given fluids. So the patient rolls into the trauma bay, and then we get the initial vital signs. You see that the kid is tachycardic and hypotensive, and she's requiring 100% of FiO2 and then with a low O2 stat, despite the 100%, which is the maximum of O2 stat you can give. And remember, she's already intubated. And in trauma, we go by the system of ABCDE to quickly assess the patient to rule out life-threatening injuries. For airway, you see that the kid is intubated and you auscultate, and you hear that there's diminished breath sounds on the right, but the left is clear to auscultation. What are your differentials here? Any show of hands. If you participate, then you may get a prize. Yes. Yes, absolutely. The kid had a gunshot wound to the right chest, so most likely, if you are not hearing any breath sounds on the right, then yes, highest on my differential is hemothorax. But what else? On that picture, on that slide, you saw hemothorax and something else? Yes, pneumothorax. This is not the real patient's x-ray, but assume that we got an x-ray. In order to diagnose hemothorax and pneumothorax, just to let you guys know, we don't need to get a chest x-ray. If the kid is acutely decompensating and the x-ray is not available, then we may have to intervene with the procedure before we proceed with radiology. But say we got a chest x-ray. Can anybody read the chest x-ray for me? Do you see a symmetry or asymmetry? Asymmetry, exactly right. On the right, you see a complete whiteout. Now, x-rays are typically done with the patient supine. So although you would imagine that the blood and water will go down to the lowest level by gravity, in most of our patients, blood will show up as something like this, where it's just complete whiteout. The left, you see that it's quite normal, right? So when someone has a hemothorax or pneumothorax, or just not even thinking about trauma, but when a patient gets a lung resection for a cancer or an anatomic abnormality, they would always come out of the operating room with a draining device. In trauma, the type of tube that we use is the chest tube. Chest tubes are hard, they're durable with a larger bore, so they're able to drain blood much better than these pigtails, which are much smaller, and so they're easier to place. However, pigtails are mainly only used to evacuate air for pneumothorax. But for blood, we go with the chest tubes. So there are two kinds of pigtails at this hospital. Reportedly, IR has even more supplies. And these are just packages of the two types of pigtails that we have at this hospital. This type, so first of all, they're called pigtails because literally the tip of this pigtail looks like the pigtail, so that's why they're called pigtails. And this part would be inside the patient's chest. Now, on the top, you see that there's a stopcock. The stopcock is useful if the provider wants to sample the blood or the specimen in the chest, so they can use a syringe to pull the sample, or they want to infuse something into the chest. And both of these are connected by this blue piece that would actually go on here. Now, the second one, we'll talk about that later. The second type of pigtail, it doesn't have the blue connector, but instead it has additional long tubing with an open funnel. So because it has an open funnel, we need that additional piece here to connect that pigtail to the chamber. And that piece is not included in the pigtail kit. It's actually on a separate kit for the chest tube. So if in the emergency room or on the floor or in the trauma bay, if the resident is doing a pigtail, you have to make sure that there's also a chest tube kit available so that you can make this appropriate connection. And then once this draining device is placed, unlike IVs where you can just place the dressing on top, you have to make sure that your dressing is really secure, and so the air cannot go in and out of that hole on the patient's chest. So we put a occlusive dressing with a Xeroform followed by gauze and the tape. So after the dressing is done, the patient will probably look like this with a bunch of tape, and they may have additional tape to secure the tubing in place. Because especially with the pigtails, because it's such a tiny lumen, it's very easy to get pulled. Now, the one thing I want to mention is that for centralized and IVs, I know that the nurses, we need your help to make sure that we change them every 3 days or however many days that we need to, or even more frequently if it gets soiled. With the chest tubes, please leave them be. Because by accident, if we actually pull the chest tube or the pigtail while you're doing the dressing change, then that's going to unfortunately require us to do additional procedure and then risk the patient of another procedure. So just call the resident and have them do this job, and you don't have to worry about it. So once the chest tube is in place and it's connected to the chamber, it's connected to the suction device. Once the pigtail or the chest tube is in, we're not finished yet. Because the chest tubes are done blindly, we have to get a chest x-ray to make sure that it's in place. Because sometimes with the chest tubes, what could happen is that it could actually go puncture through the parenchyma, the long parenchyma, or sometimes when it's done on the left side, chest tubes can be placed into the heart. And of course, so this is not a benign procedure whatsoever. So if the resident were to forget to order a chest x-ray, please remind them. And then sometimes residents, we place the chest tubes and we place the order and we have to run to the operating room and do not have time to call the x-ray tech or to review the x-ray. So then it requires our teamwork, and if you were to pick up that phone and call on our behalf, that would also expedite care for the patient. So on this x-ray, who can identify what the red arrow is pointing at? The red arrow is pointing to the line at the very top. Do you know what that line is? Any guess? Where is it coming from? Yeah, so we see that there's the line is by the arm, and then the tip is going to the middle, by the ribs, and then by the heart, right? Yes, it's a PICC line. Peripherally inserted central catheter, for any patients who may be needing it for TPN as such. Then what about the yellow line? I know it's kind of hard with all the lights in the room, but. Any thoughts? It's actually showing the edge of the lung. If you follow my arrow, it goes all the way here. Do you see that? So this is an X-ray of pneumothorax. The lung is pushed medially by the air. And finally, the blue arrow on the right is pointing at the pigtail, so it's positioned appropriately. What about this one? How is this one different? What kind of draining device do you think this one is showing? I can't hear you. I'm sorry, what? Yes. Yes. You know it because it doesn't have the pigtail, and you know it because it's got a straight line. Now, chest tubes can come in two forms. One is just literally like a straight tube that almost looks like this, and another type of tube has a 90 degrees angle. So we've got two different shapes of chest tubes. So it's time for this atrium. So when you look at this atrium, it's kind of divided into three sections. You've got the fluid collection chamber where it's draining the patient's blood or the pleural fluid or et cetera. Then you've got the middle chamber where the air comes through the suction device from the patient and then travels to the right. And this is a short clip that I want to share with you to how to set it up. Because whether it's on the floor, the trauma bay, or in the operating room, a provider cannot do this procedure alone. It requires the help of the nurse or a second surgical resident assistant. And sometimes if it's just you and I may ask you for your help in setting this up. So let's review this clip real quick.
See how fast and efficient Atrium's Oasis chest drains are to set up and use. First, remove the CSR wrap unit from the outer bag. Carefully open the CSR wrap using sterile technique and enter the unit into the sterile field. Each unit comes equipped with a large, easy-to-grip handle that makes handoff and patient transport easier and safer than ever. The sturdy swing-out floor stand should be opened for setup convenience and for placement onto the floor. To begin, fill the water seal to the 2-centimeter line with the 45 milliliters of prepackaged sterile water provided with each drain. Simply remove the prepackaged sterile water ampule from the back of the drain, twist off the top, and insert the tip of the water ampule into the suction port. Empty its entire contents by squeezing the ampule until all the water empties into the drain and fills the water seal to the indicated fill line. Discard the ampule. Next, connect the chest drain to the patient by inserting the patient tube connector directly into the thoracic catheter. The patient is now on gravity drainage or to water seal. To apply suction when prescribed by a physician, connect the suction force vacuum line directly to the chest drain's suction port located on the top of the drain. Turn the suction force on and increase the vacuum to at least minus 80 millimeters of mercury or higher. A suction monitor bellows provides visual indication of sufficient operating vacuum levels for best performance. The suction monitor bellows must be expanded to the delta mark where indicated, or beyond for a standard minus 20 centimeters of water or higher regulator setting. Visual expansion of the bellows across the suction window will confirm adequate suction operation. The Oasis suction regulator is preset to a minus 20 centimeters of water suction pressure level directly out of the package. Suction pressure can be adjusted to any desired pressure level, between minus 10 centimeters of water and up to a maximum suction pressure of minus 40 centimeters of water. Changing the regulator suction control setting is easily done by adjusting the rotary suction control dial located on the side of the drain. Simply dial down to lower the suction pressure setting and dial up to increase the level. As with any chest drainage system, the drain must be placed below the level of the patient's chest and kept in an upright position. Bubbling from right to left in the air leak monitor must be present to confirm an active air leak. The Oasis graduated air leak monitor allows visual detection of air leaks from a low volume of 1 to a larger air leak volume of 5.
So what that means is when you have the chest tube or the pigtail for pneumothorax, the way that you know that the patient still has air in their chest in the pleural space is by seeing the bubbles right there. If the bubbles are no longer there, let's say you have placed a pigtail for the pneumothorax, and then the next day when we round on the patient, we no longer see the bubbles. What do you think that could indicate? You no longer see, you saw bubbles yesterday and you no longer see bubbles today. What do you think that suggests? What was that? Yes, that's most likely the case, but can I prove that just by looking at the chamber? No, why not? Yes, I need the chest X-ray because the pigtails and the chest tubes, they could get kinked. So then if they're kinked, then the air cannot evacuate from the chest, and as such, you will not see the bubbles. So before we pull any chest draining devices, the surgical team will almost always likely get a chest X-ray to confirm radiologically. So your role in taking care of patients with chest trauma, the first, of course, it involves the patient care, and the second is documentation. For patient care, we think about observation, listening, and palpation. So for observation, of course, we would have to observe our patient. How is the kid breathing? What's the O2 sat like? Is the kid using his or her belly or intercostal muscles to breathe? Or is the kid breathing comfortably? Then you look at the chest drainage system. And as the video kind of alluded to, this chest drainage system is a very intricate system, and you really have to look at everything. We look at the chest tubing first. If a patient came in with hemothorax, blood tends to clot. And even though this tubing is pretty wide, sometimes we see clot in the tubing that is blocking additional evacuation. So oftentimes surgical residents would strip the tubing to get rid of that clot. So we are looking at the tubing. We're also looking at the suction. So when you see the patients, make sure you check the suction on the atrium with the patient's order. If the order says -20, then please check for us that it's at -20. Then you also look at the chamber. What's wrong with the chamber example here? Yes, it's full. If it's full, then it's no longer doing its job. And we rely on our nurses to help us change the chamber when it becomes full. But of course, please help us with the documentation so that we are up to date as to how much has actually emptied. Then you listen and you auscultate. And then finally, you also seal for any crepitus. When we remove the pigtails and chest tubes, we do it very quickly and in a manner to prevent air going back into the chest. But sometimes, either because the seal is not good enough or because of the wrong timing of the pull of the tube, there could be a lot of air in the sub-Q. So patients could develop sub-Q emphysema. Generally, it's contained and it shouldn't expand. However, it could expand to the point that if it comes to the neck and to the face, then that could cause patients to have respiratory compromise. So please check that as well. Now, for the order set, so this is the view that I have when I place chest tube orders. As you can see, there's many different orders here, but the one that's most important to us is the chest tube to suction, chest tube to water seal, and to clamp. Water seal is basically another word for gravity, leaving it to gravity. So instead of having the suction here hooked up to the suction device, you're not going to have anything here, and it's just going to be draining by the gravity. And it's important to note that this always has to be below the patient's chest, the level of the patient's chest. Clamp the chest tube. You're not going to do it. It's mostly the surgical resident who's going to do it as they're rounding, and then to change the order. What it means is that this one doesn't have the clamp, but it literally, there's a clamp attached to this tube, and sometimes they would actually clamp it to mimic the environment of not having a chest tube, to see if air would reaccumulate before they actually pull the tube. And if a patient has bilateral chest tubes, please ensure that there is laterality to it. We try to make a note of that too, but sometimes when it gets chaotic, we need some additional eyes to check our orders. And in most of the cases, our suction is at -20. But in rare circumstances, it could be a -10 or -40. So also always make sure that you see and you verify with the surgical team what the suction level should be. And then finally, it's about documenting. Here is an example of how it's done. This is done 2-4 hours strict eyes and nose, and this nurse had kindly documented also the quality of it. Patients who come through the trauma bay, they may initially start with a hemothorax, but that could turn into empyema and get infected blood. So if you notice that there's any change in the color from, let's say, red to brown or milky color, then please notify us and also document it. And then these are just an overview of alarming signs. For symptoms, increased work of breathing, lethargy, because when patients are not breathing well and they're retaining CO2, they will become lethargic. And then, of course, a change in the vitals. And pretty much what they're all referring to is that the tube is malfunctioning and the surgical team needs to investigate. Any questions? All right. Yeah.
Did you talk about the two different, like the big collection container versus like the pediatric one?
Oh, no.
This is very important.
Do you want to say it? Because you know more about it than I do.
Oh, sure. So can you hold that one up?
Oh, this, yes.
Okay, and can you show it on the screen too?
Mm-hmm.
No, just like put it in front of your face. There we go. Perfect.
Okay.
That way everybody online can see. Okay, so this is the atrium that is like the pediatric atrium. And then that is the adult atrium. Can anybody tell me what the difference is between the two of those? Who said cartoons on one? Okay, perfect. That's the only difference, is that one has a bear and a palm tree on it, and the other one doesn't. Now, there is one more big difference. The one with the bear and the palm tree only can take a little bit of fluid. The other one can take a lot of fluid. People in the trauma bay were using the pediatric one so often because, well, I mean, we're a pediatric hospital. Why not use the bear and the palm tree? But guess what happened? It filled up real quick, especially with like a 15-year-old. And then we would have to constantly change them out. So we've removed all of the ones with the bears and the palm tree in the trauma bay, and we only have that one. So if you're on the floor or in the PICU or wherever in the hospital and your patient has a chest tube and they're going to put one in, I would always say err on the side of using that one, not the bear and the palm tree one. I mean, unless you're in the NICU. But that's just food for thought of like the bear and the palm tree. It's just little.